Morning, everybody. And when Karthik gave me his talk, I almost became paralytic because suddenly I didn't know what to write about it. So I think my talk can follow what Dr. Pandey was talking about. He treated some of his patients of pseudo paralysis with his graft jacket or dermal allograft. My doubts regarding pseudo paralysis started because usually the moment we say pseudo paralysis with the irreparable cuff tear, we are already thinking of a reverse shoulder process. And we know that we cannot do muscle transfers when you have complete pseudo paralysis. You should have at least 90 degree of elevation. That's what Gerber describes. So that's the indication for a latissimus dorsi transfer. You cannot do a latissimus dorsi transfer for a patient who has 30 degree or 40 degree anterior elevation. But when I was discussing about people who have started doing superior capsule reconstruction, I was doing superior capsule reconstruction, but for those patients who had at least 80-90 degree elevation, not for those with complete pseudo paralysis. But when I was discussing with people like Dr. Mehta and other people across congresses, they were saying that they could be able to, reverse pseudo paralysis with superior capsule reconstruction. And that's when I had a doubt what exactly they are speaking and what I'm speaking. In fact, when I reviewed the literature for this particular topic, I understood that the term pseudo paralysis itself is not very well defined and different people use it differently. And unless we define what is pseudo paralysis, we can't exactly say what we are reversing and with which technique we are reversing it. Initially, the term was used in the context of rotator cuff tears, and it was first used by Rossler. It usually indicates the severity of the functional disability for the patient. It may or may indicate the severity of the pathology, but indicates the severity of the disability for the patient. But you cannot do anything overhead activity. And it is supposed to indicate the severity of the underlying pathology also. The only thing we agree as on today about pseudo paralysis is only about pseudo. It's not related to neurological problem, it's related to rotator cuff pathology. But apart from this, everything else is being widely varied in its definition and the way it can be, understood. Werner, in 2005, I believe, is defined pseudo paralysis. In fact, he used the term pseudo paralysis, not pseudo paralysis, as an active elevation less than 90 degree in the presence of free passive anterior elevation. That means there is no restriction of passive motion, it's only restriction of active motion caused by a massive rotator cuff tear. This definition seems to be okay, but same time, this is how exactly looks like. So he has limitation in active movement, but his passive movements are fine. But there are different drawbacks to this definition. It's not very perfect. So we'll see what it means. So before we discuss about the definitions, available definitions, and what are the modifications that have been suggested and all that, so coming to biomechanics, we see so many rotator cuff tears, but not every cuff tear gives you pseudo paralysis. There are few biomechanics mechanisms were suggested to cause pseudo paralysis. One such thing is a breakage of the rotator cuff cable, the suspension bridge concept, which was educated by Buckhart and all. And they say at least one attachment of the cable should be broken, either anterior or posterior. Then the patient can become pseudo paralytic, either anteriorly near the bicipital groove attachment at the supraspinal subscap junction, or posteriorly near the lower part of infraspinatus. If the rotator cuff cable breaks, then that can cause a pseudo paralysis. And similarly, the anterior cuff seems to be the key in causing pseudo paralysis because it has been observed that only 20% of patients with massive cuff tears will develop pseudo paralysis with intact subscap. So that means if an intact subscap, most of the times even if you have a large cuff tear, still you are able to do overhead activities. And this we see, not many times at the clinic that patients come to the large cuff tear, but still they are unable to do some overhead activity. It has been suggested that if somebody has a complete subscap tear, like in Colin type B, or a 3-tendon tear like Colin type E, there is a possibility that the patient can develop pseudo paralysis. And again, if somebody has a tear which involves inferior part of subscap, and that patient can develop a pseudo paralysis. These are various possible mechanisms of tears which can cause, or morphology of tears, which can cause pseudo paralysis in that particular patient. But again, we do come across patients with similar tear patterns. We have seen a similar case 1 week ago with an MRI scan at our clinic, and that patient has 100-120 degree elevation, and I seen somebody yesterday with the same tear pattern but 20 degree elevation, not more than that. So what is related to this? Can we say something intrinsic to that particular patient which can protect him from developing a pseudo paralysis after having a similar amount of tear? There's something called SAM index, what we call a shoulder abduction moment index, where it's a ratio between rotator cuff moment arm and deltoid moment arm. I'm not going to details of all those things, but that means we know that the rotator cuff moment arm has to balance the deltoid moment arm to prevent the superior subluxation of the humeral head. So this can be calculated by this kind of method where you can draw a circle, one covering the humeral head, which can represent the rotating cuff movement arm, and again another circle which has a center at the humeral head, but the periphery of the circle is at the subacromial space or the undersurface of the acromion. So when you have a ratio, if the ratio is less than 0.77, these patients have high risk of developing pseudoparalysis with a similar cuff tear. If the ratio is more than 0.77, these patients have less risk of developing pseudoparalysis with the same type of rotator cuff tear. So again, another finding in this particular article that was given is a larger diameter of humeral head. Somebody having a large humeral head probably are protected more against developing a pseudoparalysis. That means you have a large cuff tear, but again you have a large humeral head, probably you may not develop pseudoparalysis. But there are certain questions. Is the definition standardized? Definition of pseudoparalysis is standardized. Why elevation only of less than 90? Why not less than 45? Why not 0 degree? And again, both pseudoparalysis and pseudoparalysis are equal or different. And what are the options for treatment? Because in literature it has been described pseudoparalysis was successfully treated by partial cuff repairs, complete cuff repairs, cuff repair with patch augmentation, muscle transfers, RSA with lateral muscle dorsal transfer, hemiarthroplasty, SCR, everything. So many types of treatments, and majority have been reported successful. So somebody says I did a cuff repair and my patient's pseudoparalysis has disappeared, and somebody says I did a reverse process and my patient's pseudoparalysis disappeared. Are they talking about the same pseudoparalysis, or are they talking about different pseudoparalysis? Is the current definition sufficient? No. So because sometimes we do come across a patient like this, injury to the shoulder, unable to lift the shoulder, we think it's a rotator cuff tear, get an X-ray is normal, get an MRI scan, we do find undisplaced GT fracture. And it's a common thing what we see in OP. And then you give him 2 to 3 weeks of time, the pain comes down and we'll be able to do overhead activities. So that means we cannot say this particular patient is suffering from a severe pathology just because he cannot do overhead elevation because of pain. So pain is an important factor in seeing somebody who is really pseudoparalytic, somebody who is being paralytic because of pain. So giving a subacromial injection with somebody with pseudoparalysis will give an idea whether the pain is the one which is causing inability to do overhead activity, or is the muscle weakness which is causing inability to do overhead activity. So similarly, that's what I'm saying, some acute traumatic tear with pain causing less than 90 degree elevation cannot be equated to a rotator cuff tear with massive retraction and again a muscle atrophy. We cannot equate both the things, they're the same. So we require a proper definition of pseudoparalysis to know exactly what subset of patients we're treating with this particular treatment, and with this particular treatment, what is the success rate we're having. So in a systematic review in 2017, Hawkins et al., they told that the term in literature was being used but not defined properly, and whenever it is defined, the definition was so variable, you cannot come to a proper conclusion about this. And again, most of the times in the articles that have been reviewed in this particular thing, they identified that pain was not ruled out as a cause for loss of motion. That means not many of the investigators were giving subacromial injection to rule out pain as the cause for this pseudoparalysis. And again, if you see Mehta's articles, it's described something called moderate pseudoparalysis, severe pseudoparalysis. Again, pain was not ruled out as the cause for pseudoparalysis. And profound pseudoparalysis, again, another term was given by Burkhardt et al. So that means there's a lot of variation in the definitions. So Hawkins et al., they told that pseudoparalysis can be defined as 0 degree elevation, that no elevation at all, without significant pain, associated with superior anterosuperior escape of the humeral head and normal passive elevation. And again, pseudoparalysis is something like hemiplegia and hemiparesis, pseudoparalysis and pseudoparesis. So some elevation up to 90 degree, but not beyond 90 degree. Again, pain excluded, and normal passive elevation and no anterosuperior escape. Again, they described something similar for external rotation also, not just for elevation. Probably the ideal definition has been suggested by Bugs et al. In their article in 2017. Pseudoparalysis may be defined as less than 45 degree anterior elevation, because this 45 degree elevation could be from the scapulothoracic joint, not from the glenohumeral joint. That means the glenohumeral joint dysfunctional, but the patient can still do some 30-40 degree elevation from the scapulothoracic joint. This is like a it's a trick movement kind of thing. Pain excluded as the cause. That means that this paralysis is not because of pain, and this term should be used along with description of chronicity of the condition, and traumatic or traumatic nature and fatty atrophy of the muscles and AS will give a better idea for us to to have a proper diagnosis and to plan for a proper treatment of these kind of patients. Of course, this is an algorithm given by Hawkins et al. To give you an idea how we can treat patients with pseudo paralysis. In younger patients, probably have try rehab and partial repair and etc. superior capsule reconstruction. Elderly individual, you can go for RSA. And again, when you have an arthritis, you can go for RSA. And somebody has a pseudo paralysis with anterior superior escape with a chronic cuff tear and 0 degree elevation, probably you can think of doing an RSA. Thank you very much.